Hello there. My name is Dr. Rakesh Jain, and it's my pleasure to welcome you to this session titled Bipolar Disorder Across the Spectrum, Novel Screening Tools and Treatment Options. This activity has been supported through an independent educational grant from Intracellular Therapies Incorporated. While I introduce the speakers for this session, if you haven't already done so, please take a moment to answer the polling questions. You should see them on your screen. Depending on the device you're using, the questions will either appear to the right of the live stream or below. These questions will be asked again at the end of the program. We definitely appreciate you answering the polling questions. It's my pleasure to introduce our two speakers for this session, Drs. James A. Jenkins and Dr. Jessica Whelan. Dr. Jenkins is a staff psychiatrist at Emerson Hospital, and Dr. Jessica Whelan is the owner and CEO of Holon Inclusive Health System and adjunct faculty at Maryville University. You can type in your questions for the presenters in the Q&A box to the right of your screen, as well as upvote questions submitted by other attendees if you want to see their questions answered. We will try to answer all of the most popular questions with the time remaining at the end. So without further delay, let's begin the session.
Hello, everyone, and welcome to our presentation for Psych Congress Elevate. And we're presenting today, myself, Dr. Jessica Whelan, and Dr. James Jenkins are presenting on bipolar disorder across the spectrum with novel screening tools and new treatment options. We do want you to know that this activity has been supported by educational grants from Intracellular Therapies. We have our faculty disclosures listed as above. I'm sure you can read those, so I won't go in through them, but yes, we do have our own disclosures. We have been also informed to discuss that we're not discussing the off-label or investigational uses of products, and the use of any of these off-label products, you want to be aware, not approved by the U.S. Food and Drug Administration. So even though we will be discussing these off-label investigational uses, just remember that we'll identify some of the issues going along with that. So what we want to kind of go through with the learning objectives today is we're going to first identify different tactics to identify bipolar disorder and then what medications and implications. So I'm going to mainly cover the how to identify bipolar disorder and what kind of patients we're really looking for today. And then Dr. Jenkins is going to cover more of the section that's going to relate to the treatment options and kind of new fun emerging treatments that are going to be available on the horizons.
And I'm really excited to share some of those novel therapeutics that are coming out and have some data that's actually really new and exciting to share with you all.
Burden of bipolar disorder across the spectrum and kind of looking for that patient with bipolar disorder. This is actually kind of a topic that's always been near and dear to my heart. I speak a lot on products that have to do with bipolar disorder. And I feel like this is a population that although we as clinicians feel like we know that patient in our head, it's kind of like a migraine patient. We think we know that patient, but really this patient is still going undetected. And why is this patient going undetected? Why are we really missing that person, especially when the morbidity and the dysfunction and disability are so high? So when we kind of look at this slides and some of the statistics available, we're looking at a patient population that can have work loss up to 80%, and 45% of these patients can be sick during long-term follow-up. That to me is not very great statistics for a prognosis, but it also tells me that we have a lot of room where we as clinicians can make a giant difference in patients' lives if we're getting better at narrowing in on finding those patients and then treating them with the new treatments that are available. We also know that most of these patients are presenting in their depressive episodes. You can actually see in some of the statistics that 81% of patients with bipolar 2 disorder are usually presentational in a depressive state and 70% with that bipolar 1 disorder. So really that's when they're coming to the clinician first and foremost, is usually in those depressive episodes. And people used to say, oh, it's because, hey, they're in mania, they're not going to want to come see you. That may be true, but even in hypomania, that can be really difficult for the patient and the family to identify and really figure out what's going on when you don't have that person there. I don't know, do you feel the same, Dr. Jenkins, when you have people coming in?
Absolutely. I think part of the problem is that the depressions tend to account for so much of the actual illness that just by probability you have more chance of seeing a bipolar patient who's depressed than one who's hypomanic or manic.
So, clinical progression for bipolar diagnosis, and this is probably one of my favorite slides as far as looking at diagnosis in that patient, because we have this long delay differentiation. And I see this all the time because I like to joke that I work with the lifespan in psychiatry, that I work from birth all the way until death. So I'm really looking at those juvenile patients a lot of times when they're starting to come in and there is that strong family history. But what's always been amazing to me is how most of them and the majority of them are diagnosed with that major depressive disorder first. And something that's always kind of worried me about that is if we're missing this patient and they're actually a bipolar disorder, and especially in a juvenile onset, you may be risking putting them into a manic or hypomanic episode when giving them the wrong treatment. And this can be very dangerous for a patient and even more so for a juvenile. So for me, it's been always imperative in practice to really try and key in on, is this a bipolar disorder or is this a major depressive disorder? And what am I going to do if I'm kind of sitting on the fence and I'm not really sure quite yet because the history is not fully there? What am I going to do to really help treat this patient? I don't know if you've seen the same, Dr. Jenkins.
Absolutely. And I think one of the things that I often struggle with is like, what's a quick way to make that determination? How do we very quickly identify whether a person might be more bipolar depressed or depressed? And I think actually you're going to talk a little bit about that.
Yes, 100%. And 12 to 17% of those patients won't be, and I think this is probably an understated statistic, of patients aren't recognized as bipolar disorder until they actually switch into a hypomania and mania. So what are you going to do with that first presentation coming in, which is probably, like we said before, a big chunk of these patients are coming in with their first diagnosis being depression. And so how are we going to differentiate that in the person that may not have that clinical history? And so we're going to actually also follow a case study. And so we have a case presentation to give you to kind of capture that and encapsulate what we as clinicians can kind of do for that quick and really trying to screen, and what we should be really thinking about when we have that depressive patient in front of us. We should not just be thinking about screening for major depressive disorder, and almost every EHR now today has integrated the PHQ-2 and PHQ-9, but what are we really doing to make sure that we're differentiating out that bipolar depression that's probably just as likely, if not more likely, to be sitting in front of us, especially depending on age of patient. So with this telemedicine consultation with Vanessa, you're going to see she's going to talk about her history of depression since childhood. She's experimented with alcohol and cannabis, as most patients. I am a huge fan of genetics. They generally always self-medicate to their genetics, in my experience. So when there's imbalances, they're really just trying to fix what they're feeling is dysregulated. And then I'll tell my patients, alcohol is just a really crappy mood stabilizer. Although it may feel great in the second, it's not going to help your mood long term. But they do try and do that. And then treated with SSRI, she's been kind of through the gamut. And then she's identifying these spurts of high energy. And then we're going to look at a screening tool on how she's differentiated.
So Vanessa, I understand you've been struggling with depression for a long time.
Yes, I've taken, I don't know how many antidepressants over the last few years, but none have really been all that helpful. So I'm hoping that maybe I can get a stronger antidepressant.
Well, let's take a few steps back and try to get a clearer picture of what's been going on for you. When was the very first time you were aware of any sort of problems with your mood?
Well, I remember in grade school feeling really sad and sometimes just wishing I wasn't alive. Nobody noticed because I was really good at hiding it. And then in high school and college, I started self-medicating with alcohol and a little bit of weed here and there.
What did that do?
Well, I got wasted, but I never got undepressed.
When did you first see a mental health professional?
In college, I went to the Student Health Center and they gave me an SSRI, which really did nothing. And then after college, I got a job at a design agency and I got sober. I did see a psychiatrist on and off, but like I said, I was taking a lot of antidepressants and I still felt really depressed.
So when you say you still felt really depressed, was it constant depression, or would it come and go or change in any way?
I don't, what do you mean?
Well, some people find that depression comes and stays without varying, day after day, week after week, month after month, year after year.
I guess there'd be some times where I wasn't consistently depressed.
Well, during those times, would your mood be normal?
What is normal?
Well, normal for you. Even. Good self-esteem, normal energy, sleep?
Sometimes I wouldn't sleep much at all.
Oh, when would that be?
I don't know. Like spurts of when I was just like, go, go, go.
Can I send you a quick rating form that asks some more about those times when you had the go, go, go spurts? If you can fill it out, it's pretty brief, but it can give us some useful information about better understanding the kind of depression you've had.
Okay, sure.
Okay, I'm emailing you this now. It's a short survey. It's called the Rapid Mood Screener. It has 6 yes/no questions. Go ahead, fill it out now and tell me what you score.
Okay, so I filled out all of the questions and I answered yes to all of them.
Interesting.
Does this mean I'm bipolar?
It's a possibility. This is just a screener. So let me ask you some more questions to clarify if that's okay. On the screen for questions 4 and 5, which ask about being more talkative than usual and thoughts racing through your head and being unusually happy, outgoing, or energetic.
So the next part, and what I loved about kind of watching with this video, is with those obstacles to bipolar identification. And I think what you guys kind of saw before in the clinician offering the RMS, or that rapid mood screener, the best part was that she went through the screener, and although all positives were marked, she still continued forward to go ahead and do a deeper dive. And I always tell that with any clinicians and my students that I'm working with, screeners are great rapid tools, and a lot of times they'll lead us in a direction, but don't rely on that. Just like a PHQ-9 might say, yes, this person has depression, but does it tell you that whole story? You're still going to have to go dig. And that's exactly one of the things, especially our patients with bipolar disorder are really clamoring or needing for us to do as clinicians, is do that deeper dive. So
I would add,
sorry,
that one of the things that I think that the prescriber did really well was to actually stop and ask about the episodic nature of the patient's symptoms, which oftentimes when we give a screener, patients have a hard time sort of separating out and thinking in terms of episodic versus kind of continuous or chronic problems.
Yes. And actually, that's interesting that you mentioned that, because in practice, what I'll do a lot with my patients, even when I've used the MDQ, I'll actually use it as a snapshot time. And I'll tell them, I want you to apply this MDQ as if you've only been taking it over 2 weeks. And then I want you to do this one as if you've applied it over your entire life. That way I can get kind of some of those nuances teased out of some patients. And I feel like a screener like the RMS, you can do similar things so that patients can help compartmentalize that a little bit better, since they do struggle with that. So diagnostic screening tools, and how are we going to identify this patient? What can we do when we're in this practice and we got this depressed person in front of us? What are we going to do in order to really get down to the nitty gritty? So what they looked at here is we have studies looking at the mood disorder questionnaire. I've always joked in practice that it was one of my least favorite questionnaires, because it was always like, yes, we can diagnose bipolar 1. But for someone like myself who likes the nuance, I felt like there was some lacking in trying to pick up on those more subtle changes of like cyclothymia or bipolar 2. And a lot of patients would, as Dr. Jenkins talked about, a lot of times they have trouble putting that in that episodic nature or how to kind of rate it over time. So if some patients are only thinking that past week and they're not thinking of applying it over their entire life, actually, I have this a lot with my like 60-year-old or 40-year-old patients coming in. They're not applying it to when they had more cycling, which some of them happened in their 20s. And so they totally forget that part of their life. They've been in depression for 20 plus years and depressive episodes. So it's like they forget, and you have to drag out that information. So just giving an MDQ and saying, hey, oh, this person's completely negative, so clearly they can't have bipolar disorder. That's doing a dissatisfaction to your clients if you're not actually doing that dig and making sure they've applied it over their entire life. So that's something that I've always made sure to impress upon students and on patients on when and what time frame they need to really put this in context. So we do know that this is a very sensitive test and specific test, less so with the general population getting that sensitivity, but that specificity is pretty spot on. Like I said, it will get you your bipolar 1. If they're got all yeses, you pretty much can feel pretty confident. But at the same time, it may risk screening in other things. I've had this problem, especially with autism disorders and other obsessive compulsive disorders and things like that. I don't know about you, but I've had patients that flag off incorrectly and can have that mood disorder. And that's why, again, doing a deeper dig is important afterward. What do you think, Dr. Jenkins?
I agree. I've always found the MDQ to be more helpful for screening out bipolar disorder. And I think the numbers that you have up there reflect that. It has a much higher negative predictive value than a positive predictive value. So oftentimes when someone screens positive on this, it's a signal and something to take into consideration. But again, it's a screener, it's a questionnaire, so a lot more, as you've been saying, a lot more digging is necessary. That being said, when someone has a completely negative MDQ and I'm not finding anything else in the history, I oftentimes feel more confident in my diagnosis of a unipolar depression.
100%. I think you said it right there. When there's nothing else in that history, then you can feel that confidence because that history and clearing that after they've marked all negatives, again, you said it right there. I did a deeper dig and I found, hey, there is really nothing else here. And that's done our due diligence. And so what we've also seen is that lower MDQ predictive value in mood disorder patients with comorbid substance use. So if they're using substances, we're not going to be able to clearly get as good of a picture. And that makes sense because substances are more likely to cause this dysregulation and up and down. And that's why they've always said, I know in nursing school, it was always like, make sure that the patient doesn't have a, substance use disorder first. And you have to treat that before you really make that diagnosis of the mood disorder. And this is exactly right. Because if they have this substance use on top, it's going to be more likely to cause issues in the ratings being more clean and more accurate when you're using your screeners like the MDQ. So what we have, this new tool that's kind of coming to market or use, is this rapid mood screener. What I like about this screener in particular over the MDQ is it is a lot quicker to apply in practice. So when you're offering like a PHQ-9 and another tool and maybe like 2 or 3, it's nice to have a 6-question questionnaire that also offers a good specificity, sensitivity, and predictive value. So this one is kind of giving us that good sense of really trying to get down to the nitty gritty in a couple short questions. And then we can go on into that deeper dig. What do you think, Dr. Jenkins?
I really like this screener, and one of the reasons why I really like it is because it does have a little bit more of a balance between the positive predictive value and the negative predictive value. So is where the MDQ is good at screening out bipolar disorder and for picking up people at risk of bipolar disorder, positive predictive value. isn't quite as good. Whereas I think what you're showing here is that the rapid mood screener has a little bit more balance in that it's both good at screening out and also screening in people who will eventually go on to have a diagnosis of a bipolar disorder. It's fast and it's easy. It's great.
That's 100% why I think applying something like this into practice, it's easier to add on if you're using other screeners, and you're going to be more likely to get that positive or negative screen out, whichever that you're needing for patients. Again, I don't want to underemphasize the importance of going back and getting more history when you can, but when you don't and you need that tool that's going to be more reliable for you, that's something that's nice about having, like Dr. Jenkins said, a balanced approach when you're doing your screening tool. And especially, I think one of the key points in here is having that question, did you have problems with mood before age 18? I think that's a huge one, because we've talked about in the literature frequently about early onset of diagnosis and then episodic nature, which is also kind of brought in here when it's talked about having these periods of less sleep and periods of feeling energy, is a little bit different and nuanced in the way that it asks questions that I think leads it to being that more balanced screening tool that we're needing. And so other corroborators, and that's kind of linked into exactly what we talked about, episode characteristics. So have you had these episodes? There's fewer hypomanias potentially in the DSM-5 mania, or fewer for hypomania, up to 20 points when we have that. The family history, that's huge. So if there's that first degree relative, especially bipolar disorder, highly heritable, as opposed to MDD, it has heritability, but generally less so than the bipolar disorders. At age of onset, so again, that adolescent that I'm seeing coming in, I'm highly suspect when I have a depressed adolescent coming in, and very much making sure that I'm almost, as a rule of thumb, starting at bipolar disorder and wanting to rule it out first. Rather than jumping to, oh, this is a major depressive disorder, like what they kind of used to do. And I felt like for me, I start at bipolar disorder because I'm going to run less risk of kindling or not diagnosing. So if I kind of start at that episode and say, hey, I have to rule this out before going to this next one, I feel like it just, again, toggles that mindset of how I'm going to approach to not miss that bipolar episode in an adolescent patient that might be presenting. Obviously, we also talk about response to treatment. So if there's a recovery with mood stabilizer or a manic switch with antidepressants, that's always been talked about. Hey, watch for that mania, but not every patient, and I see this a lot in clinical practice, is going to flip into mania just because they got an antidepressant and they have the bipolar disorder. Some of my patients, they say, actually feel better. A majority of them will say, yes, I felt better, but it's like living your life in black and white TV versus Technicolor. So I feel like a lot of my patients, they may feel a little bit better and they don't want to go to suicidal and they don't want to go back to where they were, but they're still not fully where they could be for total wellness. So I think that's kind of very important to consider when we're looking at that course of episode or course of illness, a lot of high recurrence. That's going to be something that's going to be important. So our key learning points and all of that, and hopefully what you took away before we get to exciting neuroreceptors and things like that, is that we really need to differentiate for our patients who's that bipolar 1 disorder versus who's having MDD. And in that depressive episode, we need to do our due diligence using our screening tools and then doing a dig into the history. And that's what's really going to help make sure we don't miscategorize our patients. And so I'm going to turn it over to letting Dr. Jenkins run the conversation on our next part.
So thank you for all of that very helpful information, Dr. Whelan. And now it's time for a little bit more of an in-depth dive, and this is going to feel like it's coming at warp speed, and that's because it is coming at warp speed into the treatment of bipolar disorder, and some updates that hopefully you can immediately incorporate into your clinical practice. But there are also some things that are on the horizon and things to be excited about to look forward to for the future, because the reality is that this is a hard population to treat. With Vanessa, who we saw, who's coming with complaints of depression, you can already see the frustration that she's had with the kinds of treatment that she's had before in the past. And fortunately, I think in the clip that we saw, she had some openness and willingness to consider different treatment options, but clinically, that's not always what we see. So let's talk about the treatments that we have available at our disposal for bipolar disorder. And when I'm talking about bipolar disorder, I'm talking about the bipolar spectrum, so bipolar 1, bipolar 2, and essentially we have 3 different classes of treatments that are included in the evidence-based guidelines. We have mood stabilizers, and mood stabilizers, their role is most useful for maintenance treatment. And part of the reason for that is because they are a little bit more specific to the polarity of bipolar disorder that a person may be in at a particular time. They're better at preventing future episodes, and they're quite slow to work. With the exception of Depakote, valproic acid can be used in a way that makes it work rather rapidly, but some of the other mood stabilizers take some time to actually take effect. Oftentimes antidepressants are used in the treatment of bipolar disorder, whether it's intentionally or unintentionally, but the reality is that there have been multiple meta-analyses that look at the evidence for this practice, and there's never been any demonstrated efficacy for the treatment of bipolar depression with traditional antidepressant medications. The medications which are used most commonly in today's clinical practice, primarily because they have the broadest spectrum of activity, are second generation or atypical antipsychotics. They can be useful in mania. A few have some antidepressant effects, and we'll talk about why certain ones have antidepressant effects and others don't. And there's not really clear evidence about whether or not these medications are effective for maintenance treatment, again, with some exceptions. The problem with antipsychotic medications is that in comparison, they often have a high degree of side effect burden that the patient has to live with while they're taking these medications. So in general, this is the approach that a person would take in treating someone who has bipolar disorder. And this is coming from a consolidation of the most evidence-based guidelines, including CANMAT, including the NICE guidelines, including the APA guidelines. So if a patient presents to you in your office and they're in a manic or a mixed episode, which hopefully you're able to identify a little bit better now, given the information that you were just provided, the first thing that you want to do is eliminate the antidepressants. If they're on a mood stabilizer, you want to check levels and then make sure that the level's optimized. And then you really want to focus on restoring normal sleep-wake cycles, which can really have profound effects on stabilizing mood. So oftentimes on an inpatient unit, for example, this is why we'll have people on short courses of benzodiazepines at nighttime to ensure that they're getting sleep. Now, it's a little bit more tricky when a person presents to you in a depressive episode like Vanessa did. Because we know that our typical treatments for depression, antidepressant medications, are not very effective. That being said, we do know that there are certain second-generation antipsychotics that have some evidence, and thus far, the ones that have evidence include lurasidone, cariprazine, quetiapine, olanzapine, and also the combination of olanzapine and fluoxetine. There are other therapeutics that are on the horizon that I'm going to be talking about. One really exciting one is lumateperone, which is a newer second-generation antipsychotic, but there's also evidence accumulating for the use of modafinil, pramipexole, ketamine, which is very much a hot area of research and study right now in psychiatry. And then some nutritional supplements, including N-acetylcysteine and omega-3 fatty acids. Also, we can't forget about neuromodulation as a potential treatment. And again, in the maintenance phase of bipolar disorder, primarily the recommendation is to use some evidence-based mood stabilizing medicine, for example, lithium or lithium plus divalproex, Divalproex has some evidence, although not as good as the other two. So for the maintenance treatment of bipolar disorder, as I already mentioned, the evidence is primarily for the use of mood stabilizers. When choosing a mood stabilizer for that patient who comes with recurrent manic episodes, the evidence release is in favor of the use of lithium, which is better at treating manic episodes than depression, although also offers some protection from depressive episodes. Divalproex, the story is a little bit more complicated. It's failed in trials for maintenance therapy, but it can be used as a preventative strategy or it can also enrich an anti-manic response. The BALANCE trial looked at the combination of lithium and divalproex and found that it was better than divalproex monotherapy, but about equal to lithium. There's no evidence right now for the use of carbamazepine, and lamotrigine, which is often used in contrast to lithium, is much better at preventing depressive episodes than in preventing manic episodes. But it does have some evidence for the prevention of mania. So when do we use antidepressants? So like I had mentioned earlier, the meta-analysis really seemed to demonstrate that there isn't great evidence, although the clinical practice is a little bit in contradiction to this. So if you are going to use an antidepressant in a patient who you suspect has bipolar disorder, the patients who it would be less harmful for would be someone who has a diagnosis of bipolar 2, has more pure depressed episodes rather than mixed episodes, has no history of rapid cycling, no real history of mania or hypomania. So essentially someone who looks very much like they have a unipolar depression, but maybe has that family history, or maybe had the early onset, or has had some success with an antidepressant medication in the past. For maintenance therapy with second generation antipsychotics, the evidence is still accumulating, and right now the primary ones that we think about are aripiprazole, which seems to be helpful for the prevention of mania, but not so much for the prevention of the depressive phase of bipolar disorder. Asenapine prevented mania or depression, but that was a one trial that was positive. Lurasidone had a negative trial for maintenance therapy. Olanzapine had 3 positive randomized controlled trials. One of the trials looked at it versus placebo, others looked at it versus lithium or divalproex. Quetiapine probably has the broadest amount of evidence associated with it for the prevention of mania and depression and as a maintenance therapy for bipolar disorder. What is the cause of the difference between the different response and efficacy for second generation antipsychotics? Why are some helpful for depression, some are helpful more for mania, some are more helpful as a maintenance therapy? A lot of that has to do with the fact that each of the different second generation antipsychotics has a very unique binding or receptor binding profile that includes some mix of activity on serotonin receptors and on dopamine receptors. And there are specific ones that I want us to just kind of focus in on because they have some importance for some of the research that I'm going to be reviewing that's coming out. One of the main ones I want us to focus on is this serotonin receptor 5-HT2A, which is the receptor that really is associated with the atypical nature of second generation antipsychotics. When this receptor is antagonized, it can increase prefrontal dopamine and it can enhance attention, motivation, memory, and it mitigates some of the movement disorder. So it's this antagonism of this receptor that really kind of differentiates second generation antipsychotics from first generation antipsychotics like haloperidol and others like that, which were primarily just dopamine blocking medications. That being said, second generation antipsychotics do still have effects on dopamine receptors. And the ones that I want to take a look at are these receptors over here. So the dopamine D2 receptor which classic antipsychotics or first-generation antipsychotics are often strong blockers of. This is the receptor that's also associated with those Parkinsonian symptoms that are often problematic in the treatment of patients with bipolar disorder. Another receptor that is actually very much being researched right now and very interesting is the D3 receptor, because certain atypical antipsychotics have particular ways in which they interact with the D3 receptor. Aripiprazole and brexpiprazole, cariprazine are examples of second-generation antipsychotics that have a very unique way that they interact with these receptors. This receptor has, when it's stimulated, can enhance motivation, or if it's stimulated too much with a pure stimulatory effect, can exacerbate psychosis or compulsive behaviors. When it's partially blocked or inhibited, it can have antipsychotic, antidepressant effects, and most interestingly, can also reduce cravings for substances. So whenever we're thinking about a second-generation antipsychotic, what we want to be thinking about is the unique kind of fingerprint of the mechanisms and that the antipsychotic works, and how it affects these different receptors. So to go back to that serotonin 2A receptor that I talked about, which is really the kind of the defining feature of many of the second-generation antipsychotics, we know that the strength with which that receptor is blocked has some impact on efficacy. One way of looking at the strength that this receptor is blocked is by using something called a Ki, which is the concentration of the molecule that has to be present for half of the receptor's activity to be sort of shut off. So the lower the number, the lower the concentration has to be, and the stronger the medication is at blocking that particular receptor, although that doesn't necessarily relate to clinical responsiveness. You can also see on the left here a PET scan showing the distribution of where these receptors are found on the brain. And you can see that there's a really high concentration of these receptors in a lot of the cortical areas, and also in the prefrontal areas. So whenever we look at these medications, another thing that we can look at is the ratio of how much dopamine versus how much of the serotonin receptors are being affected. And one really interesting thing about lumateperone is that the strength with which it interacts with the serotonin receptor is about 60 times as much as the strength with which it interacts with this D2 receptor, which again is associated with those sort of Parkinsonian side effects. So we may expect from looking at a ratio like this, that this may be less likely to produce symptoms such as EPS-like symptoms. So I sort of briefly talked about the interesting nature of this D3 receptor and how if it's partially stimulated, it can enhance motivation, concentration, and when it's partially blocked, it can have some impact on reducing psychotic symptoms. And this is really interesting because it essentially medications which act on this as partial agonists, so they're partially stimulating, partially blocking, can help the brain to function in a more sort of natural way that it normally would. And these receptors are particularly distributed in the reward pathway of the brain, so the ventral tegmental area, the nucleus accumbens, and project up to the prefrontal cortex, which is associated with executive functioning, attention, planning, motivation, all these things. So another part of the story that's becoming more evident during the research is the role of glutamate in psychiatric disorders. And so now one of the things that we're looking at is how interaction with some of the dopamine receptors may change the overall balance of glutamate in the brain. And as you can see right here, some of the different antipsychotics, which impact the D1 receptor, which has a downstream effect of modulating glutamate levels in the brain, that certain medications have different degrees of activity on this, which again contributes to their individual fingerprint or and why one patient may respond preferentially to one versus another. Glutamate, by the way, is also the primary molecule that is thought to be implicated, and the glutamate receptors are thought to be implicated in the role of the use of ketamine for the treatment of psychiatric disorders. So olanzapine, which is very often used for the treatment of bipolar disorder, has with it the side effect of pretty significant weight gain. And so one drug that combines olanzapine plus a mu-opioid receptor blocker that's very similar to naltrexone, and that's called Samidorphan, actually was recently shown in a study to attenuate and to decrease the amount of weight gain that patients who are placed on olanzapine for manic or for mixed episodes experience while taking the medication over 24 weeks. And so you can see here that about 80% of people who take just olanzapine by itself will have some degree of weight gain associated or an increase in weight whenever they're taking the medication. And over time, you can see this is the population of people that gained more than 7% of their body weight, and the percentage of people who gained more than 10%. You can see that the combination of the olanzapine and the Samidorphan actually decrease the number of people who are gaining more than 7 or 10% of their body weight, which is really exciting to think about, that we might have the ability to prescribe olanzapine while simultaneously being able to mitigate some of the weight gain associated with it. Another combination that's being looked at is the use of lurasidone plus D-cycloserine, which is a molecule that acts on that glutamate system, on the NMDA glutamate receptors, and NRX-101, which is currently in phase 2B and 3 studies, is being looked at as a maintenance therapy to extend the response that the patient with bipolar depression has after they receive IV ketamine infusions. And what's being shown is that for patients who are given this combination of lurasidone plus D-cycloserine, which acts on the glutamate receptor, the response that they have for bipolar depression to ketamine actually seems to sustain and extend better than for someone who's just taking lurasidone by itself. And so you can see here that at 14 days after the infusion, there's a clinically significant difference between those people who are taking NRX-101 and those people who are taking the lurasidone. One of the main challenges of doing IV ketamine infusions for bipolar depression is being able to sustain the response. And so this is incredibly exciting to think that we may have some drug that becomes available to us that will sustain the response that a person might have to ketamine infusions for greater periods of time, and might even end up decreasing the number of infusions or the amount of time the person has to be exposed to ketamine. Although that's not what this study is showing. This is simply just showing the length of response after the infusion. Lumateperone, which I had mentioned, has been shown to be therapeutic for the treatment of bipolar 1 and bipolar 2 depression. We talked a little bit about the unique mechanism of action of that medication. And so you can see that for the number of patients who had a 50% decrease from their baseline MADRS was significantly greater for people taking lumateperone at 42 milligrams versus those who were taking placebo. And the number of patients who completely remitted from a bipolar depressive episode also increased. So you had 40% of people who achieved remission who were taking lumateperone versus 34% who were taking placebo. And this is at day 43, and the study was an intent to treat analysis. Some of the other novel pharmacotherapies, so these are drugs that are being looked at as potentially being repurposed for the treatment of bipolar depression, include both modafinil and armodafinil. And so there are at least 2 randomized trials which have shown some beneficial effects. Pramipexole has some evidence. The anti-inflammatory agents, which are also thought to have some neuromodulatory functioning, like N-acetylcysteine, omega-3 fatty acids, have some degree of evidence as well. And then again, ketamine is being looked at for the treatment of bipolar depression. And there are at least 3 randomized trials which have shown an increased response rate. And these are the odds ratios right here at day 3 or 4 after receiving an IV ketamine infusion. So the odds ratios have ranged anywhere from 4 to this one is in 15. So the key learning point to take away from our exploration of these novel agents is that there are some drugs that are available for bipolar depression, which is very difficult to treat and for which we have a limited amount of options right now. And these include NRX-101, which is that combination of lurasidone plus D-cycloserine, which was shown to extend the benefits of IV ketamine infusions. And then also, as I've mentioned, lumateperone is showing evidence for the treatment of bipolar depression. There's been a recent phase 3 randomized double-blind placebo-controlled trial of lumateperone, which I reviewed, which showed improvement in the MADRS scores in patients with depressive episodes, regardless of if they were associated with bipolar 1 or bipolar 2. So to come back to Vanessa, so as we saw, Vanessa's past suggests that she's had periods of elevated mood, that there's been some episodic nature, and that she's had poor efficacy with antidepressant medications. And so this is someone that you may want to think about starting on a second-generation antipsychotic, like lumateperone, to see if she gets a better response for her depressive symptoms. So why don't we see how Vanessa's doing in follow-up?
Hello, I'm happy to see you back today. How are you feeling?
I think I'm feeling better.
Can you expand on that? Tell me what that means to you. What have you noticed that's different?
I don't know. I feel like myself again. I feel, I don't know. I feel good.
How's your depression compared to the last time we spoke?
I don't know. It's hard to really know. I just feel better, and I'm not having any of those nights anymore where I'm just laying down in bed waiting for my brain to shut down.
How about impulsivity? Any thoughts of behaviors that are elevated or abnormal for you?
No, not really. I mean, I went to a few parties with friends, and everyone was having a drink, and I was tempted because, it's a social thing. We get together, have a few drinks, but I didn't. I knew I would feel worse, and so I'm glad I didn't do that.
How's your appetite? Any increases or decreases?
I think I'm eating more now.
More than 3 times a day?
Well, no, I was only eating like every few days. Now I'm eating a few times a day.
Have you been going to your therapy? Like, as we previously talked, that medications help even out your moods. Remember that therapy is necessary to ensure the best outcomes.
I know. I will try to be better about keeping my appointments.
So are you comfortable continuing the current medications? And we'll follow up in 1 month to make sure you're still doing well? Because if at any time you're not feeling well, just call here and we'll get your appointment moved up.
Okay, that works.
There is an importance for using some sort of rapid or quick rating scale or screen for bipolar disorder so that you can get to the right diagnosis and eventually get to the right treatment. Also, you want to make time to explore those features which may hint towards a diagnosis of a bipolar spectrum disorder. We've talked a little bit about the differences between mood stabilizers and second-generation antipsychotics. Those things that have anti-manic versus antidepressant efficacy, so that hopefully you can better tailor your treatment to the individual patient. And we've also looked at how the mechanism of action of second-generation antipsychotics might contribute to their specific efficacy for bipolar depression. And we reviewed several emerging or novel pharmacotherapies and how we may soon be incorporating those into our clinical practice. So thank you very much for your time and attention. At this point, are there any questions?
Well, welcome back, everybody. Before we jump into Q&A, please be sure to answer the post-activity questions to the right side of your screen. Please click the Submit button after the last question to successfully submit your answers. And as always, thank you so much for answering the polling questions. And also, thank you so much for such an excellent presentation, Dr. Jenkins. We appreciate you. Dr. Whelan's line is giving her some trouble, so Dr. Jenkins has agreed to serve as the primary point of contact for Q&A. And our audience has some really good questions, so we're going to jump right into it, James. So here's the first question. How are you able to differentiate between mood symptoms of bipolar disorder from mood symptoms of borderline personality disorder?
That's such a great question, and one that I have a lot of intimate knowledge about. So there are a couple of things that I would suggest. First and foremost, the same risk factors that you would look at to differentiate whether a person is likely to be unipolar or bipolar, you would want to take into consideration in trying to distinguish whether or not someone has borderline versus bipolar. So a strong family history of bipolar disorder is something that may sort of push you in the direction of considering bipolar disorder. Another consideration when they've done really large factor analysis to look at the distinction and how to better diagnostically clarify, one of the things that they found is that patients with borderline personality disorder have much less positive affects. So they tend to not really ever go into more of like a euphoric or pleasant period of time, unlike those with bipolar disorder. People with borderline personality disorder tend to have more irritability and dysphoria. And then, of course, the other thing that you want to look at is external sort of factors having an influence. In particular, you want to ask about interpersonal challenges. And if there seems to be a really strong correlation between breakups or rejections or interpersonal conflict and mood-related symptoms, that is more suggestive of borderline personality disorder.
Got it. It's a tough differential, isn't it? And
it is.
And it doesn't help that they're so often comorbid either.
Exactly. And I believe it's about 20 to 30% of people are comorbid. So there's also always the possibility that it's both and.
Yes, I certainly hope you'll be coming back for future presentations, future Elevate meetings to elevate our knowledge base about this pretty challenging issue. Well, unfortunately, we only have time for that one question. And James, that it breaks my heart to have to say that to you because there are so many great questions. But for another time, thank you everybody for joining us again today. And be sure to check out the Innovation Theaters coming up next. Visit the live agenda page to see the full session details. And do remember, attending Innovation Theaters earns all of us extra points towards Earn While You Learn competition. Enjoy the rest of the conference.